I've been asked to talk this morning about my approach to patellofemoral instability. To think about the patella instability, I like to look at the data about what the natural history is. What kind of problem do we actually have with the kneecap? And if you look at a review of the natural history out of 189 acute dislocations followed prospectively, the most common determinant of instability is for the patient to be a teenage girl. And the predictors are that about 50% of the people who have had a dislocation will have a second dislocation. But if you have one dislocation, the likelihood of you having another one is only about 17%. So you have a better than 80% chance that your kneecap won't go out again if it's gone out once. The MPFL, the retinaculum, the VMO injury on MRI actually resulted in a lower risk of subsequent dislocation on this report. In the Scandinavian literature, out of 127 first-time dislocations randomized to operative and non-operative treatment, we found that at 7 years, the non-operative group was doing much better than the operative group. And so the recommendation is that surgery for primary dislocations doesn't make sense. Not only does it end up with a poorer result, but it's unlikely that your patient will have a second dislocation after a first time. And this is the only level 1 study in the literature that compares long-term follow-up of a surgical and non-surgical treatment. Well, there are always exceptions to every rule, and one exception is a loose body. If you take an x-ray after somebody's had a kneecap dislocation and there's a large bony loose body in there, I would go in arthroscopically and remove it, but I would not at the same time do a ligament patella stabilization procedure. If there's a large osteochondral fracture or persistent lateral subluxation, I think those are also indications for some intervention. In this particular article published in 2007, their recommendation was that a substantial disruption of the MPFL and VMO was an indication for surgery, yet that disagrees completely with the previous study I mentioned in 2004. So how do we make the diagnosis? Well, there's a number of different physical examination factors: tenderness, tracking, Q angle. But the reality is, I think a careful history is most important, because the physical examination tests are very subjective, and the sensitivity for patellofemoral physical tests is less than 50%. There are confounding variables. There's the Carter-Wilkinson score, in which if somebody has 4 out of 5 determinants, such as hyperextension of the elbow, hyperextension of the knee, being able to bring the thumb down and touch the forearm, being able to bring the small finger back to 90-degree angle, or being able to put your palms flat on the floor, 4 out of 5 is a positive sign for hyperlaxity, then that confounds your problem. Age also has a significant impact on patella instability. It's usually not a disease of an older adult individual. It's a disease of a teenager. So what about the radiologic assessment? I think AP is an important view, but the most critical radiologic examination is the true lateral, in which the condyles overlap posteriorly. Merchant in 74 described a tangential or skyline view taken at 45 degrees of flexion. That was the original description. Now we take those at 30 degrees of flexion. And from the true lateral, you can gain a number of important pieces of data. You can identify the patella height. You can look for evidence of trochlear dysplasia and its severity. You can look for patella tilt by overlapping the medial ridge with the lateral facet. And you can look for the presence of arthritis and spurring. There's a number of different patella height measurements: Insall-Salvati, Blackburn-Peel, Canton-Deschamps, and we use the Insall-Salvati pretty much all the time in my clinic. Other measurements you can get from the view is the crossing sign and the TT-TG distance on MRI or CT scan. Insulsivati was described in radiology in 1971, and it's the comparison of the length of the tendon to the patella height. And the important number is 1.2. If the ratio is greater than 1.2, then you have a problem. You have patella alta. Blackburn-Peel is an index which is a little bit more complex to calculate, and the Canton Descamps is a very similar number to the Insulsivati. In other words, if it's greater than 1.2, then you have a problem. And this is taken, of course, from de Jour's article this last year. Trochlear dysplasia. Dr. de Jour described in 1987 and later on added to this the crossing sign. And the way you calculate this is you look at the trochlear floor. Now, the trochlear floor starts at the beginning of Blumenstadt's line and runs up to the anterior aspect of the femur. And where the trochlear crosses the anterior lateral femoral condyle, at that point the trochlear is flat. And the more distal that goes, the worse the dysplasia. And there are different classifications, and I think the type C and type D has been noted to be the most challenging. The tibial tuberosity trochlear groove distance can be measured on CT scan or on MRI. It has excellent intra and inter-observer and interperiod reliability, and it measures the lateral tibial tubercle displacement. The take-home number here is greater than 20 millimeters, and if you have a TT-TG distance greater than 20 millimeters, you've got a problem. The control is around 12. Operative decision making. There are two broad classes of types of operations, the way I look at it. You've got soft tissue operations and you've got bony operations. Under the soft tissue operations, there's the isolated lateral release, there's medial tightening or the medial reefing, and then there's the MPFL reconstruction that Dr. de Jour was talking about. On the bony side, you've got tibial tubercle osteotomies. You have a pure medialization, which is the Elmsley-Trellat. You have the anterior medialization, which is the Fulkerson, and you have trochleoplasties. And then to make things more complex, you can use soft tissue procedures in combination with bony procedures. Well, let me make a comment about the isolated lateral release. It is not really indicated for instability. Lateral releases reduce the lateral stability up to 20% and has a potential for iatrogenic medial instability. I never do an isolated lateral retinacular release. If you are going to do a lateral release in association with some other procedure, it must maintain some vastus lateralis obliquus support. But the long-term results of the isolated release are inferior and they deteriorate with time. So when do you do a lateral release? You do it after an MPFL reconstruction or medial capsular reefing. You don't do it before because you want to go ahead and tighten your medial side before you release your lateral side. Otherwise, you could over-tighten the medial side. You release just enough to bring the patella tilt beyond neutral, and you have no more than 2 quadrants of medial glide. It is not needed for all instability operations. So the indications for a proximal stabilization or a distal stabilization in my hands are recurrent lateral instability of the patella. Now that means at least 3 dislocations. Soft tissue medial deficiency, in other words, the medial retinaculum or MPFL is incompetent, and especially if you have open growth plates. Because if you have open growth plates in one of these teenage girls, you don't want to be messing with the tibial tuberosity because you could interfere with the growth. The contraindications for proximal stabilization are medial facet chondral damage, a bony cause for the instability such as trochlear dysplasia. And the other thing I would point out is that this operation is not for pain or arthrosis. So we'll talk about some of these. Medial plication. This was initially described open. In recent years, arthroscopic assisted, all arthroscopic medial plication procedures have been advocated. Ron Yamamoto in the Arthroscopy Journal in 1986 described the first instance of arthroscopic medial plication. Jeff Hulbrick in 2001 talked about his series of repairing these things arthroscopically, and then we reported in 2006 using a radiofrequency probe with leaving untreated strips between the radiofrequency strips for medial plication. Our radiofrequency treatment showed a 91% success rate in 53 knees at 53 months, and that means only 9% were having recurrent instability, which is equivalent to other sides. MPFL cadaver studies. Dr. DeJure just talked about a lot of information about the MPFL. To reiterate, it contributes 53% of the restraining force against lateral patella displacement. It's the primary restraint of the patella, and MPFL reconstructions can involve gracilis, semitendinosis, quad tendon, fasciolata autografts, or allografts. MPFL is not, a reconstruction is not indicated for a primary dislocation. In a 2008 level 1 study with a 2-year follow-up of 80 patients randomized to MPFL repair or brace, there was no difference in the redislocation rate or any of the objective outcome scores between those who were operated and those who were not operated. The indications for the MPFL reconstruction are recurrent instability with poor medial tissues. As the trochlear dysplasia increases, the need for an MPFL graft also increases. It may be of additional benefit with patella alta and failed procedures. I do not feel it's indicated for an attempt to pull a sublux patella into the trochlea, and if there is medial articular cartilage damage present, I wouldn't do an MPFL because you'd be compressing the patella against the damaged articular cartilage. And it's not indicated to compensate for gross malalignment, significant valgus, tibial femoral torsion, or an abnormal Q angle. Moving on to bone procedures, Elmsley-Trellat, Fulkerson, trochleoplasty, and these are often combined. Now, to the tibial tubercle osteotomy, there are two schools. There's Lyon's school of thought in which patella alta and trochlear dysplasia are problems to be addressed for patella instability. And then there is the U.S. school, which is divided, as usual, and we get good results with a tibial tuberosity translation alone, with an MPFL repair, and with an MPFL and TTO combined. Distal realignment, medialization of the tibial osteotomy was first described by Roux and then by Elmsley and Trellat. The Fulkerson osteotomy was described first by Fulkerson in 1983, and it was designed to treat arthritis. It was not designed to treat instability. It has subsequently been applied to instability procedures. The goals of both of these is to correct the TT-TG difference. Good cartilage with minimal chondrosis on the side to which the patella is being transferred is critical. Medialization must normalize the TT-TG distance. Now, biomechanical data shows that flat cuts and oblique cuts don't make any difference. And while medialization procedures, overall, there are lateral contact pressures, it is important to lower the tibial failure load with greater fracture risk with the Fulkerson oblique osteotomies. They can be a problem. Elmsley-Trellat has a lot of good results. You want to displace the tibia distal on a hinge and move it 1 centimeter medially. And here's the cut difference. The contraindication is a crush lesion on the superior patella. My treatment, to summarize all this information, my treatment algorithm for patella instability is with a first-time dislocation, you treat the patient with physical therapy, anti-inflammatories, and time. If there's a loose body, I would go ahead and do surgery, but that's the only time I would do that. Indications for surgery are multiple dislocations. If there's a recurrent dislocation with open growth plates, at that point I would do a medial reefing, suture plication with a lateral retinacular release. If this fails, an MPFL reconstruction would be indicated as long as there isn't significant medial chondrosis. If the growth plates are closed and there's no chondromalacia and the TT-TG distance is less than 15 millimeters, I would scope the patient's knee and do the medial reefing and lateral release. If the TT-TG distance is greater than 20 millimeters, I do an Elmsley-Trellat. And the reason I do the Elmsley-Trellat instead of, say, a Fulkerson is the speed with which you can return a patient to activities, such as athletic activity, is much greater with an Elmsley-Trellat. If there's lateral chondromalacia, I would do a Fulkerson. If there's a failed prior repair and the TT-GG is less than 15, I do an MPFL reconstruction. So in summary, proximal stabilization operations are for traumatic instability. Distal alignments are for pain and instability associated with bony or tubercle malalignment as a primary inciting factor. Thank you for your attention.